Welcome, everybody. It's always a pleasure to be at Columbia. I've never been in the Miller Theater before. I won't sing. I'm going to talk about artificial intelligence today in medicine. In medicine, unfortunately, we've been waiting years for computer science to help us practice better medicine. And every other industry, if any of you shop in Home Depot or you go to Target or you go to IKEA, you realize that none of this could exist without a very sophisticated back room of computer scientists and data extraction and management. In medicine, we're still dealing with paper records. So what I hope to show you today is what's out there, what's possible, and what are some of the things that we're doing in artificial intelligence. First, I thought I'd frame the discussion by just reminding everybody some of the obvious things that physicians do. We establish a diagnosis in a patient. I'll talk a little bit about artificial intelligence and how that helps us. We choose optimal treatments, easier said than done. We just heard a discussion of how challenging that can be. And then we manage conditions that can be diagnosed. And I'm going to speak about each of these three in succession. First, let's talk a little bit about how we're doing in medicine. And we're not doing very well, honestly. There is a lot of data showing just in diagnosis alone, forget about the management talk we just heard, in diagnostic issues alone, probably represents 20 to 30% of medical error. The diagnoses are missed, delayed, or just frankly incorrect. And then treatment and management is also a problem. There's a landmark study showing that patients probably get less than half of the things they're supposed to get recommended. And generally, physicians don't follow guidelines. I have my reasons for why I think that's true. I think it's largely that they can't access the information. So let's talk firstly about diagnostic assistance with artificial intelligence. What is out there that could, or that's being developed, or maybe that some person in this room is going to help develop? What's out there that can improve diagnostic accuracy? So this is where I'm sitting here interacting possibly with an iPad, maybe mumbling conditions into the machine as clues. And so for example, this is all data run through Watson's system. A patient has uveitis, which is an eye problem, family history of arthritis, what disease or condition can cause uveitis. And we see that there's a differential diagnosis. And one of the major errors in diagnosis of physicians is that we don't have a big enough differential diagnosis. We think of a couple common things and then we don't think deeper than that. And one of the things that's fascinating about Watson's output to me is that Behçet's disease is actually a pretty good diagnosis here. It's very uncommon. And what this brings up is the idea that the machine has to reconcile two different conditional probabilities. First of all, we ask, what's the probability of Behçet's disease given this symptom, uveitis? And it's actually pretty uncommon. It's not a common disease. If I was in the emergency room, somebody walked in with uveitis, I wouldn't necessarily think it's Behçet's disease. But then there's another conditional probability, which is the opposite. Given Behçet's, what's the probability of uveitis? And that's actually pretty high. That means most people with Behçet's disease have uveitis. And my only point here is that a human can't reconcile these conditional probabilities. And only through computation. It's too complicated, and there are probably many other conditional probabilities. So if we just go back to this list and we see this list here, this is the result of having weighted the different conditional probabilities. Let's add some physical exam findings: circular rash, fever, and headaches. Patient has, again, uveitis, and we just heard about that, now complains circular rash. And the suggestions flip over completely. And I like to refer to this as Watson turning on a dime. That Watson has completely eliminated from the main diagnosis, and is very confident in Lyme disease, one kind of disease, autoimmune diseases, and now is considering infectious disease based on the appearance or the entering into the database, the circular rash. And I'm going to talk later on about diagnostic bias. One of the other problems that we have as physicians is we get fixated on the first thing we're thinking about. And it's very hard to move us over to another realm. And I'm going to, in this case, it was from autoimmune disease to Lyme disease. A machine has no problem. And I'll show you a slide of that, summarize that later on. So we have an example of where I sit and interact with the machine. But far more interesting, in my mind, is the scenario where the machine operates on its own. Like you're at home and you've been to work all day, you saw your patients, and your patient's at home, and the electronic health records sitting up at Columbia or Mount Sinai or St. Louis, et cetera, and the machine is operating on its own, looking for potential diagnoses. So we ask, can the machine diagnose a patient's condition without having the information entered? And the answer is yes. One of those things we're working on at Columbia. Can the machine figure out if the patient has kidney disease? Now that's an easy diagnosis for the machine because there's a simple blood test that almost everybody who's ever within a 3-mile distance of a hospital gets that blood test. And so the machine's going to know if the patient has kidney disease. And then we can further ask the machine to tell us whether or not the providers know. So how would we go about doing that? We have the EHR, the electronic health record, which of course is the hub of all the electronic data. We've got what we call structured data, simply Excel tables, for example, where the blood test for kidney disease is listed, and we have some demographics. And we have, part of the machine has an algorithm that tells us how to calculate kidney function, which in this case is the estimated GFR. And then we have a set of rules using the date and the eGFR. We can ask if the patient has kidney disease. The doctor doesn't need to interact with this. The machine can do this. And in fact, we have such a machine running as we speak. But a more interesting question is, does the doctor know the patient has chronic kidney disease? Because if they don't, then there are a couple things that can happen. One is we can tell the doctor that the patient has chronic kidney disease, and we can offer some guidelines on how to manage that case. So how would the machine know if the doctor knows that the patient has chronic kidney disease? And it can look through the notes. Now, this is easier said than done. This is obviously unstructured data. This is what we use natural language processing for. These are sophisticated algorithms that go through and figure out what these words mean. If the doctor wrote chronic renal insufficiency, we could train the machine to say, well, that's recognition of chronic kidney disease. We did a study last year where we showed that about 1 out of 5 patients with chronic kidney disease, there's no mention of that in any of their notes. So we can ask a similar question about a disease such as myasthenia gravis. And I picked myasthenia gravis for a couple of reasons. One is there's between a 2 and 5 year delay from the time a patient develops these symptoms to the time it's diagnosed. And 2, there's no simple blood test. There's no routine blood test for myasthenia gravis. And so what kind of machine is going to be able to figure that out? And that's where we have to ask the machine to be able to do some sophisticated natural language processing. And it's going to have to look for the signs and symptoms of myasthenia gravis. We have 2 sets of signs and symptoms. We've got medical terms, dysarthria, dysphagia, ptosis, diplopia, but we've also got the patient's terms. The patient, theoretically, unless they've been through medical school, doesn't know or doesn't use the medical terms. They may say to the doctor, I have difficulty speaking, or I'm having double vision. And in the electronic note, either or the medical or patient's terms could be written, and this machine is going to have to be able to figure out what those terms mean. So we can look at our currently available decision helpers out there, Isabel and Watson, not commercially available yet. But if you put in the medical terms, actually the products find myasthenia gravis. It's right up there. You put in those terms, the medical terms I just showed you, and you get the diagnosis. Isabel is a little more sensitive. Watson's a little more specific. They're not bad. These other diagnoses are pretty good. Some of them are a little too general. Watson's diagnoses are actually all characterized by those signs and symptoms. And then not completely true of Isabel. By the other hand, Watson missed some of these more common conditions. But I think a more interesting question, at least to me, is how did these systems do with the patient's words? Not every patient is going to use the medical term. Not every doctor is going to use the patient's terms. And again, we plug in those terms. Isabel does not get myasthenia gravis. He gets a couple things which are a little general. Watson does a lot better in terms of finding diseases based on the patient's words. This is all to say that the systems that are going to troll through the electronic record late at night when everybody's asleep are going to have to be really good at knowing that some of these common terms, difficulty swallowing, are equal to the medical terms and are synonymous with them. So this, in my mind, is an example of passive diagnostic support. It's happening when Nobody's actually entering any of the data and asking for an answer. Now let me finish with the diagnostic portion here and talk about reasoning biases. Physicians are plagued with clinical reasoning biases. I mean, we are as humans when we try to come up with decisions for our daily life, we often get biased and led down the wrong path. And for years I thought, when I taught the students at Columbia, I thought that if we just all practice the scientific medicine, we'd never be led down the wrong path. We'd always make a rational decision because we're using the scientific method. And then Jerry Groopman, who was a brilliant scientist, he went to Columbia Medical School, he wrote a book on all the errors that he made because of clinical reasoning biases. And I'm going to show you what they are in a second. I mentioned one already, anchoring, where you get fixated on one diagnosis and you can't move over. So this is much of the buzz now, and I think that the only solution, honestly, for physicians to get around their biases is for artificial intelligence. So here are some classic biases that have been shown to cause medical error. One is premature closure. We don't think broad enough. We have a couple things on the diagnosis. Behçet's up there, and I didn't think of Lyme disease. We need help to broaden the differential diagnosis. What we call base rate neglect is we over or underestimate the probability of things. So, you know, we hear hoofbeats, we think of zebras instead of horses. Obviously, zebras are far less common. But then we often forget that there are zebras out there, and we might not think of the uncommon disease because it's so uncommon, or we under or overestimate its probability. So once again, I think the machine can help reconcile opposing conditional probabilities and give a very broad differential. We have overconfidence bias. I love when my junior colleagues say we never see that. Most of us, even if we've been practicing for years, haven't seen everything. Machines can deliver the best evidence and match the information needs of the user at the bedside. And I already mentioned anchoring, where you get fixated to those autoimmune diseases. There was Behçet's and sarcoid, and then lo and behold, we told Watson circular rash, and Watson had no problem going to an infectious disease, whereas a physician would have been, and it's been shown, much harder to move over to a new diagnosis. Let me move on to choosing optimal treatment. Here, much less has been done. Diagnosis is sort of easy. People were always skeptical of that. The diagnostic space isn't that big. I mean, there are literally a finite number of ways that people get sick. That's been true for thousands of years. Our understanding of what causes the illness, of course, progresses on a daily basis. And what progresses exponentially, perhaps, is how we understand best to treat the patient. But managing treatment is far more computationally difficult and challenging, I believe. So I'm just going to talk about one aspect of that. How can artificial intelligence improve treatment? And the key, of course, is to match the patient to the treatment. And we just heard about randomized controlled trials. We study drug X within, in a patient with and without heart disease. Well, often these patients are very narrowly defined, certain age group, no other comorbid conditions, not on any other drugs. The treatment for your patient is not going to match that patient. Your patient is going to have many illnesses, be on many drugs, especially as chronic disease progresses. And the hardest thing is to find the treatment that matches the individual. So we need, a simple example in my mind is hypertension. We don't need AI to diagnose hypertension. I mean, you can go to Walgreens and stick your arm in the cuff, and it will tell you have high blood pressure. But the complication arises, first of all, there are numerous genes already known to result in hypertension. Some of these drugs, some of the genes or products will be affected by some drugs and not others. And so we're going to have to keep track of which drugs are good for which genetic abnormalities, and we're just at the beginning of this. I mean, in 10 years, we'll probably have 50 genes. Also, any of these drugs that we choose may have adverse events in some patients, but not others, because of their genetic background. And then we have drugs that interact with the patient's other drugs. And so this might be the perfect drug for that patient's genetic abnormality, and there are no side effects in that patient, but oh gosh, they have this other condition that might cause that drug for that to interact with this drug. The metabolism and efficacy is affected by other comorbid conditions. Who's going to compute all this? A human is not going to compute. It's not humanly possible. But that's what we need. I mean, if a person comes in and needs to be treated for high blood pressure, we need to take all those things into account. We can't just throw up our hands and go, well, it's too complicated, I can't deal with it.
And I show a decision tree. We teach decision trees at the medical center for a good reason, that we have the students think about what the different outcomes are. This is just whether or not to treat someone with, for high blood pressure. There are all these different possible outcomes, each of which, some of which include an adverse event or no adverse event, or they didn't improve. We just heard that not everybody with hypertension who's untreated is going to end up having a poor outcome. All the probabilities have to be extracted from the literature. So I think down the road, this is what AI is going to do for us, is populate that decision tree, but at a much more complex level, because they will have there'll be many more leaves because, or I guess leaves, because there'll be all these other comorbid conditions and other drugs. And I always show this picture of my mother-in-law, Shirley, who's no longer with us, unfortunately, but she loved when I showed this picture. This was a typical patient, in their mid-70s. She had all these conditions, all of which are affect each other, and for which she needed this bag of medicines, and she has this big bag of medicines. She used to say to me, Herbie, look through that. Do I need all these medicines? And I'd always think to myself, of course not. And then I'd go through the list, and then I'd realize that she does. How are we going to compute the probabilities? A human can. I'm going to pick up a drug and go, well, there's a 30% chance it's going to interact with that other drug. Impossible. So this is in the future. There's nothing out there right now that populates this tree using artificial intelligence. That's down the road. Let me speak of one last example, which I would refer to. I've chosen to show something about managing the patient's condition. And we could ask, here's a question: could AI improve my management? Could AI help me understand how my patient is doing? Now, if it's a blood test, well, that's easy. If somebody was anemic and you gave them iron, the blood count goes back up, well, that's not rocket science. But how about the more complicated illnesses? It's very hard for a physician to sit in front of an electronic record with a patient, hearing the story of how they're doing, and know how are they doing. So here's one example of how AI could improve or help physicians. For example, we could ask, how's your patient with chronic kidney disease doing? You can tell I'm a kidney doctor because all my examples are with the kidney. How is the patient with chronic kidney disease doing? Are they going to get worse, or are they going to get better? If they're going to get worse, then we really need to be aggressive. Get that blood pressure down really low, maybe give them a couple different drugs. If they're not going to get better, progress, then we can perhaps be a little less aggressive, and that would probably be beneficial too. So we use data mining and machine learning, and the simplest paradigm is you take a whole bunch of patients with progression who are known to progress. Again, that's easy. The machine knows that because it's a blood test. And we take a whole bunch of patients who didn't progress, and then we use machine learning to ask, what are the attributes that are predictive of progression? And with those attributes, then we can look at an individual patient and say, well, you've got several of these attributes in these levels that are predictive of progression. We better really drill down and get you in to have your blood pressure checked more often, or protein in your urine measured, et cetera. That it helps guide us and also helps recognize where we don't have to be as aggressive. This is still in the works, but the hope is that this can be run in real time. The machine learning takes place, so Watson does machine learning in nanoseconds as it looks for answers. This can be run on the EHR. Patients have to be identified, and then you could imagine down the road a message to the physician saying, you need to be more aggressive. So I conclude by saying we need assistance. It's not humanly possible for physicians to practice medicine at the level that they would like to. It's ludicrous to think that this has probably been true for 50 years. Even though the information's out there, we can't find it, and we need this assistance in these three areas: establishing diagnosis, optimal treatment, and managed conditions, and there's plenty for you guys to do in this field. Thank you.